Every Thursday afternoon around about this time, 4:45 or so, we like to spend some time talking to Far North Queensland medical practitioners, medical scientists about current health issues here in Far North Queensland, ways of looking after yourself where we live. And today we're going to meet Cairns-based orthopaedic surgeon Dr. Sarah Coll. Orthopaedic specialists, orthopaedic surgeons deal with joints, often after injury or degenerative disease. But as you will hear, Sarah says the joints deteriorating with age, it doesn't necessarily have to happen. There are ways to avoid that. Sarah, good to meet you. Thank you for coming in to see us.
Thank you. Nice to see you too.
And you're an orthopaedic specialist, orthopaedic surgeon?
Correct, an orthopaedic surgeon. I'm trained by the College of Surgeons initially in some basic general surgical training, and then for 8 years in some orthopaedic training, which is specific to joints.
What sort of common things bring a person to your door to seek your advice?
I guess there's probably two groups of patients. The first would be ones that have sustained trauma or an injury, and that can range from anything from a massive life-changing car accident to a altercation with a circular saw and a finger to something relatively minor such as an ankle sprain. And that's one group of patients. And the second group of patients are commonly known medically as those suffering from degenerative conditions, which of course is a very controversial word and probably should be erased from the medical dictionary.
Why so?
Because degeneration is not something that has to happen. It's something that can happen, and it's something that we should be addressing sooner rather than later, and it's something that we should be putting some energy into avoiding on a personal level.
So not necessarily the case that just because we've got older, more miles on the clock that bits don't work as well as they used to. It doesn't have to be that way.
I think it's important to recognise that some people live very long and very healthy lives with very few joint problems, and I think that having joint problems is not doesn't have to be considered part of growing older. And I think joint maintenance and looking after your muscles and bones is something that you need to put energy into, just as you would put into looking after your brain and looking after your gut.
Would that come under the broad category of exercise, or is it broader than that maintenance?
Oh, I think sure, it includes exercise, injury avoidance, and I think there are components of nutrition and even psychological components, psychological health. I think all of those things, suppleness, it's not just a matter of strength. I think management of injuries is also very important as part of an overall perspective on joint health.
So into that broad but not much loved label of degenerative, what sort of conditions do you talk about in that context?
I think the thing that most people think about is the person that's having the joint replacement, and I think that's certainly a big part of degenerative joint disease, the total knee replacement, the total hip replacement, the total shoulder replacement. And while clearly some of these conditions follow significant injuries as young people, we do lump some people into the category of, oh, my joint just wore out. I'm sure there is probably a group of them, but I'm sure there's probably also an injury component to that as well. The other side of degenerative disease is degeneration of our ligaments, tendons and soft tissues, and that's things like the degenerative back with the disc disease or the degenerative rotator cuff in the shoulder. And there are questions about what the physiology is behind this, the physical mechanisms by which this process happens. And there are a lot of discussion in our orthopaedic community about drying out of tissues and tissues losing certain chemical supports or chemical scaffolding over time, which contributed to degenerative change. But of course, there is also a group of patients where we don't see this all the time, and their joints and tissues and tendons look at the age of 60 like a 40-year-old. And whether or not that's considered significant by patients is different to whether or not it's considered significant by doctors. Degeneration from a patient's perspective is very different to degeneration from a surgeon's.
In those conditions, is surgery generally the recommended path of treatment? Are there other ways?
I think every patient must give serious consideration to non-surgical treatment, and my preference is always to operate on someone who has exhausted non-surgical treatment. So there's a whole selection of options available to a patient prior to surgery, and I usually question them to see how far they have exhausted those options prior to discussing surgery. Some patients feel that they have sustained an injury and they want the injury reversed, and if that's the case, they are usually very keen to have surgery. Some patients have the impression that their condition has come on very gradually and that there are things that they can do to modify their lifestyle to address the problem. Ultimately, the decision to operate, while it rests with the surgeon, the patient has the final say in the situation. And so if the patient says that they're not interested in surgery, well, that's the end of the story. So therefore, non-surgical treatments become a part of what I do, is to discuss and inform the patient what those options are. Usually it involves a spectrum of medication, so anti-inflammatories are often an option for patients, although a lot of patients do tell me that they don't like to mask the problem. Generally, doctors like to fix the problem, but sometimes it's an appropriate option for a patient to suppress the pain, suppress the symptoms, and keep going. And that's a choice. The second option is things like splinting, so braces or small devices for hands, walking sticks, all those sort of prosthetic type solutions. And patients can often take that and run with that, and that makes the joint functional, that eliminates the pain and makes the patient overall improve their function. And of course that's what most people want, is a reduction in pain and an improvement in function. And if you can achieve that with simple non-surgical treatments such as splinting, well, maybe that's enough. There are options with more interventional things like steroid injections, and that's a commonly chosen option. And for some joints that is suitable, and for some circumstances that is suitable. But that's always a decision that you need to make based on your own personal opinions about your health and your own and your doctor's opinions about what the success rate might be and whether or not you think that's a reasonable thing to do, and whether or not there may be any injury sustained. So whether or not it's good for your joint to continue to have steroid injections. And I guess those are the main non-surgical treatments. And once they are exhausted, once you have done your best or tried to the limits of what you think you want to do, well, then the surgical option comes into play. And of course, that's not a simple process either. I think there's a lot of perception that once it's been fixed, it's done. And I think that certainly patients are starting to get the impression that the surgery is the beginning of the rehabilitation process, and there is an awful lot of input from the patient required in order to really get your function back. And I think patients are getting a much better grasp of the fact that that's a long-term investment on their behalf of time and energy and concern and worry and stress, rather than just an operation as such.
There are so many branches of medicine, so many specialties that you can go into when you qualify as a doctor. What was it about orthopaedics that grabbed you?
Well, I initially thought that orthopaedics was not a very suitable occupation for a lady. I was advised by my father that it was too heavy going because it can be quite a physical job. There's lots of involvement of chisels and saws and drills predominantly. and so I guess I really didn't consider it an option. However, as a very junior doctor, I worked for a surgeon who, when he operated, it was like watching a beautiful ballet. He never made a mistake. He never went backwards. He always went forwards, and he always fixed the underlying problem. And I guess I really appreciated that perspective, but then felt that it would be difficult as a woman to manage family and other commitments. And I thought that perhaps and that overwhelmed me. However, I was doing an operation in Cairns with a lovely surgeon who did a massive hip replacement, femoral bone replacement on a lady with breast cancer. And at the end of this epic, probable 6-hour procedure, I told him that I thought it was really cool. And so the next day he offered me a job. And I guess, I still think it's really cool. I think what we do is fantastic. It's amazing what anaesthetics has, the anaesthetics have become incredibly sophisticated in the last 15 years. And because of the availability of pain relief and safe anaesthesia in older patients, we now have the capacity to help so many more people with these surgical interventions. And they just, the patients just really blossom out of reversing injury or correcting diseased joints as such, replacing diseased joints.
Good to meet you, Sarah. Thank you.
You're welcome.